Good afternoon, everybody, and welcome to another ADAM webinar. We're very pleased that you could all be with us today, and we've got quite a crowd, so that is wonderful. I am very pleased to welcome Reggie Allen, MBA, RN, ACM, and he's going to talk to us about tackling readmission denials. He's had a ton of experience in that, and really looking forward to what he has to say. So before we get to Reggie, though, there are, as always, housekeeping items that we need to take care of. So let's get that done. All right, so you should be able to see a little control panel, just as you see on the screen here. You can open and close your control panel. It gives you options to join the audio. You can download your handouts. If you see over here, the handouts are there, ready to be downloaded. And you can submit questions in this part. And at the end of the webinar, we will do our best to answer as many questions as we possibly can. Just a little bit about ADAM. ADAM is the Association for Healthcare Denial and Appeal Management. It is the nation's only association that's dedicated to healthcare denial and appeal management. Our mission is to support and promote professionals like you working in the field of healthcare insurance denial and appeal management through education and collaboration. Our vision is to create an even playing field where patients and healthcare providers are successful, persuading medical insurers to make proper payment decisions. Our website is listed there, www.adam.org, and we are created through the generous support of PayerWatch. And just a little bit about PayerWatch. PayerWatch is divided into several sections. We have PayerWatch Appeal Masters, and Appeal Masters has trained thousands of folks in denial and appeal management, and Appeal Masters strongly believes in taking your appeals all the way for optimal results, and they use a clinical legal approach. Now, PayerWatch Veracity is the software section of PayerWatch. The software is a leader in the denial prevention industry, and it was developed to be in service to providers in protecting revenue. So if you are interested in finding out more about Appeal Masters or Veracity, the PayerWatch website is there. Now, as far as CEUs, contact hours, there seems to be a little confusion sometimes, so you're going to hear me say this several times today. Free CEUs are offered to ADAM members only. The webinar itself is free to everybody, but the CEU, to get the CEUs or the CMEs or the contact hours, you have to be a member of ADAM. The other things that has to happen in order to get the CEUs, you've got to be a member. You must attend the live webinar for at least 53 minutes. And if you're a physician, you must attend the entire presentation. And everybody must complete the survey that'll pop up automatically for you at the end of the webinar. As soon as you click out, it'll pop up. CEU certificates will be emailed to you generally within a week of the webinar. With the exception of the CMEs, there are instructions for that coming up. CEUs are not available for watching the recording. You must meet the criteria that we just talked about. And a disclosure: no individuals in a position to control content for this activity have any relevant financial relationships to declare. Now, from the survey, you will be prompted to select the CEUs that you want, as many as are applicable for you. So we have CMEs from a Medco for physicians, we have for CCDSs from Actus, we have NARI, CCMC, AHEMA, ANCC via the Northeast Multi-State Division Education Unit. So on as many as are applicable to you. Now, here is language for the physicians, for the CMEs, and I would encourage you to read this. And this is also for the physicians. And it has, in here it has objectives, which is for everybody. We'll be going through that on another slide for everybody. And on slide 9, for physicians out there, how to get your certificate. This is where your instructions are. Our next complimentary webinar, gonna just tell you now, we hope you register. Revenue Cycle 101. The CEUs are for ADAM members only, but this is a revenue cycle webinar that is geared toward non-revenue cycle healthcare providers, nurses, doctors, just some of the basic information. And you can register on the homepage at www.adam.org. That will be available after this presentation is over. Disclaimer that I must read in its entirety. Whoops, what happened there? The Association for Healthcare Denial and Appeal Management publishes and distributes materials on its website that are created by our members or invited industry subject matter experts for the benefit of all ADAM members. ADAM does not certify the accuracy or authority of these materials. These materials are distributed and presented as research information to be used by ADAM members in conjunction with other research deemed necessary in the exercise of ADAM members' independent professional judgment. ADAM claims no liability in relation to reliance on the content of these materials. The views expressed in the materials or the views of the materials authors do not necessarily represent the views of ADAM. Any references are provided for informational purposes only and do not constitute endorsement of any sources. There are no conflicts of interest to declare for any individual in a position to control the content of this presentation. Now, our learning objectives for today. So at the conclusion of the webinar, the learner will be able to identify at least 3 of the conditions included in the hospital readmission reduction program from CMS, identify 1 circumstance when a readmission may have been appropriate, identify 1 method of defending appropriate readmissions through the appeals process. And the learning objectives for nurses, and this is something that, because we have so many CEUs and CEs available, there are certain things that we have to cover. So for nurses, at conclusion of the webinar, at least 90% of participants will share in the evaluation the 3 criteria that we just talked about. And the Nursing Continuing Professional Development Activity was approved by the Northeast Multi-State Division Education Unit, an accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. So I'm happy to introduce Reggie Allen. Reggie Allen is Chief of Clinical Business Operations for PayerWatch. He has more than 35 years of experience in a variety of healthcare positions. I don't think there's a whole lot that he hasn't done. He's been recognized nationally as an expert in care management and clinical operations. He is a results-driven leader, and I can attest to that, who emphasizes operational transformation by integrating clinical and financial care aspects. He's very well educated. He possesses comprehensive knowledge and experience in all facets of care management, including case management, utilization management, disease management, quality management, and resource management. He has designed and implemented an enterprise-wide clinical appeals unit and a clinical documentation program with success. He uses Six Sigma and Lean principles and is an expert in clinical and operational efficiencies. And he's an all-around great guy. So you're going to learn a lot from Reggie. So with that, Reggie, if you want to get started there.
Will do, and thanks to all of you guys for joining us this afternoon to talk about a subject that's really important to us as a group, as we also see and tackle readmissions. We see quite a bit of those here at PayerWatch, and we've had some great success in getting some of them overturned. So I hope to share with you some of our learnings and some of the things that we've done that has been very helpful in our ability to do those. I want to start with talking about the hospital readmission reduction program because, as most of you know, most of the programs, even that you see that actually that are actually out there today, even by the managed care plans, pretty much all start with CMS. I mean, CMS starts denying everything, and then the payers start denying everything. And so CMS brought up this stuff about the readmissions, and pretty much all the payers have gotten on board. So let's talk about it a little bit. And I want to make sure that you understand a little bit about the hospital readmissions program, and then we're going to talk about some of the differences that we see in payers, and obviously as Carla talked about. We'll talk about uh, the way we kind of tackle it here at PO Masters, and hopefully we'll give you some great takeaways as some of you continue to fight readmissions. So first of all, let's the hospital readmission program from for Medicare actually started in 2012 with the goal of obviously improving communication and care coordination to engage patients and caregivers in post discharge planning. It is set up where the hospitals actually get a 0 to 3% reduction every year during the beginning of the CMS year based on what their scores are from the prior year. And it's like a 3-year look back. But that they actually 0 to 3% is what's taken off. And it's taken off the operating payment of the hospital. So the hospital has two sides. It's the operating and the capital. Both of those actually make up the payment, and it's the operating side that they actually take the 0 to 3% off. So it's a reduction to all the Medicare fee for services and stays, and so it looks at both Medicare fee for service stays and Medicare and managed care stays with dual eligibility. I'll talk a little bit about what that means so that you guys understand if you're not clear about what this dual eligibility does and why it's included. Next slide, please. Carla, next slide. Okay. So the interesting thing about this readmissions, I think, in 2018, after the CMS has started doing this for a while, they really started talking about the disparities that they see in readmissions. And as some of you know, early on, they had two tiers that they actually used. They put you in two groupings early on when they got started to actually put the penalty against people, and they changed that because they started identifying some of the other factors that may actually control or contribute to those readmissions. So in 2018, after they did a great job of doing analysis and studying, they realized that they had 2.3 million readmissions. It cost the government roughly $35.7 billion. And they identified that at least 10% of these readmissions could be avoided. And you can see when they looked at the disparities where they pretty much saw where the readmissions were occurring. So then that really helped them go through and really start talking about how we might need to look at this a little bit differently as we start penalizing hospitals. Next slide, please. So CMS to be included in the hospital in this program, you have to be first an acute care hospital. You have to be paid under the IPPS system, okay, to be eligible. The other thing is they're looking at unplanned readmissions. So most of you know when the patient is discharged, and you get to select if it is a planned readmission because the planned readmissions do not count in this program if the disposition is selected correctly. An example of that is the physician sees them, feels like they need to have a bypass surgery, so they plan something within them in the next 30 days to come in and do that. Same thing with orthopedic stuff. They come in, they see the patient, and then they say, okay, we're going to reschedule you to come back in for your surgery in 2 to 3 weeks. That discharge needs to be selected as a planned readmission because if it's selected as a planned readmission, it does not count. Next slide. So we talked about what's included. Let's talk about what's excluded. What's excluded from the program, because we basically talked earlier about those paid under the inpatient prospective payment system. What's excluded are patients in critical access hospitals, rehab hospitals, LTACs, psych hospitals, children's hospitals, cancer hospitals. The VA is excluded, the short-term acute care hospitals in the U.S. territories, and any religious non-medical healthcare institutions. The Maryland hospitals are also exempt. As most of you know, they are not paid under the DRG system, but under a total cost of care model. They do get a copy of their readmission results, hospital specific, but they are not penalized because they are not paid under the IPPS program. Next slide. So there are 6 conditions that when Medicare went back and looked at it, they said, okay, what conditions, always try to get to the 80-20 rule, what conditions actually make up the most of the readmissions that we have that we really need to work on, that if we can get those down, we can get those million dollars saved, that those billions, I'm sorry, of dollars that we're paying out in readmission. And those 6 diagnoses came back to acute myocardial infarction, chronic obstructive pulmonary disease, heart failure, pneumonia, coronary artery bypass graft surgery, and then your elective primary total hip arthroplasties along with your total knee arthroplasties. There's a lot of noise. Obviously, nothing has come out yet, but I do know, I did read where one of the things that seems to be the highest thing now with readmissions that are coming out, which the trend used to be heart failure was number 1, and now number 1 seems to be sepsis. So I wouldn't be surprised if they're not looking at a way to take a closer look at people that had sepsis, discharged, and came back in the future. But that has not been finalized yet, but it's something that obviously is being considered. Next slide. So the penalties is assessing the all-cause unplanned readmissions that occur within 30 days of discharge of those 6 that I just shared with you. They collect the data on the patients who are admitted to the same hospital or an applicable acute care hospital for any reason. So one of the things, if you don't know or know from the Medicare side, this is not, we'll talk about the difference in that on the managed care side, but on the Medicare side, you also get penalized if the patient, say, had an acute MI at your hospital and then shows up at another hospital within 30 days, in any other hospital in your area, outside your area, doesn't matter. If it's a Medicare recipient and they show back up, then of course that they would be that, and you were the index, that readmission would be accounted against you. Very different on the managed care side, which you'll talk about. It considers everything within the 30 days as an adverse event, regardless of what the principal diagnosis is. It doesn't matter. They look to see the patient had acute MI, they're back within 30 days. And so for those that are on your quality side, which I did a lot of work on, I'm sure they're looking to try to parse out what's related and what's not, what's related and unrelated. But if they come back within those 30 days, it is considered an adverse event. And so they applied the adjustment factor to all Medicare discharges in the applicable fiscal year, regardless of the condition. And that is the time frame that we'll talk about when the CMS penalties actually are in effect. Next slide. So in 2023, there were 2,273 hospitals that were penalized, which they're saying, knowing that we're getting better, it's lower than it has been in 10 years. Remember, they withhold 3% once they do the calculation. They withhold the 3% from all of the from the hospitals based on their operating payment. The average reduction was 0.43, which is the lowest it's been since 2014, which only still cost was high, was $320 million. 25% of the hospitals did not receive a readmission penalty, which is good. And then the number of hospitals that had to pay over 1%, it was 50% less than it was in 2022. So that's good news for those 6 diagnoses. We're doing a great job of actually addressing those from a Medicare standpoint. There were some pluses of that, and I'll share what some of those pluses I think that as I read and understand why they also think that there may be a significant drop and something else that they're looking into. Next slide. In 2024, but in 2023, what happened, pneumonia was not included in the penalty. And that was because of COVID 2019. And back then, when COVID first started, if you remember, there was a lot of pneumonia. A lot of it was related to COVID, which, and they had no way of actually addressing that. But now we've got more coding practices now. We now have a code for COVID. We're having fewer COVID admissions. And so they're thinking there's sufficient data that we should go back in there, because usually, as I told you earlier, they look at 36 months. But the performance period includes 30 days before July 2019 and December 1st, 2019. And then they had a gap in there between July 2020 and June 2022. So now looking at they're looking at 29 months instead of 36. And they're actually putting pneumonia back in there, but they cut the time frame of what they're going to look at, and the reason is because of the COVID. The COVID made a situation where they didn't have data. So pneumonia has been added back. It was paused in 2023. It's not paused now, but they are eliminating that period because they didn't have good codes and stuff to be able to address it. So how does all this work? Next slide. I really don't want to, what I'm not going to do, obviously, is try to teach you how to calculate it. If you want me to do that with you later, I'll do that with you privately, but not today, not in this meeting. But in order for you to be included for a condition or a procedure to be included, you have to have at least 25 discharges of that condition for it to be included. And I think the confusion by most people is the peer groups that they put them in, putting people in peer group sizes, which I thought was very good. So they use what they call a dual proportion. Dual proportion are patients that are eligible for Medicare and Medicaid, and that's important because that accounts for the influence of social risk factors for that group. Usually patients that are dual eligible for Medicare and Medicaid usually are patients who have very, very low income. And so basically what they talked about earlier, people had just a lot of managed care. They were not as high risk, because we're going to talk about that when we talk about how we can now use the social determinants of health. They were not as high risk if they were a lot of just traditional Medicare and managed care. Those hospitals don't have a higher population of people with social risk factors. They found that patients that have social risk factors that are dual eligible or Medicaid and Medicare typically are patients also are much higher at county hospital settings. So basically what they actually do, the easiest way to talk about it is they actually put you in peers based on one, the dual proportion, two would be the case mix index for those patients that are in those 6 diagnoses, because some of them have multiple issues and are high risk with other conditions of being readmitted. So once they take the case mix index of those, then account for the dual proportion by dividing the number of dual eligible days over the total Medicare and managed care stays. Once they add those together, they're able to come up with what they call their ERR. So that's your excess readmissions. And once they come up with those, obviously that lines you up into one of the 5 peer groups. And then from one of those 5 peer groups, they're able to calculate what your reduction would be. it's a whole nother lecture on that one, and I don't want to go into that into this meeting because I really want we're here to talk about appeals and how to address those. But that gives you some sense about how the HRR payment is actually done. Next slide. So here are the key drivers that that came out from the study from them, and why we're going to talk a little bit more about the social determinants of care and how we can use those in our appeals, is that the key drivers that they clearly identified for the readmissions through all the studies that they had is number one, unclear and non-compliance of discharge instructions. Complications from the treatment from the first admission, lack of primary care providers for these patients to be sent to when they are discharged. So we'll talk about that in time of discharge. They looked and saw that there were language barriers, that there was healthcare literacy that patients that really didn't understand. We were not doing a great job of providing them with culturally competent patient education as well as education at their literacy level. Their restricted access to socioeconomic resources, their mental health patients are high risk, obviously many of you know, for readmissions. Then this advancing of their chronic disease process and comorbidities they have. And then obviously there was just some that were non-related visits. And they also found that many of these cases with some of these, other than the non-related, there was no relationship. They came in with CHF, they went home and failed. There's no correlation between that whatsoever. But these are the key drivers that they identified. If you look and group them together and understanding, I know we have a lot of case managers out there, and you are staff. I know that you guys can see the correlation with a lot of these with the social determinants of health. The language barrier, the not having providers in their neighborhood, the healthcare literacy, the socioeconomic processes. These things are all related, obviously, to the social determinants of health, which has become a big issue with Medicare over the last year or so, and it's why they are making it also part of the assessments that they're looking for as part of discharge planning of patients. Next slide. Now, let's talk about the commercial and the Medicare Advantage plans. They typically do follow CMS guidelines. However, you really have to refer to their contract or provider manual, which is very, very different. They don't allow separate reimbursement for claims that have been identified as readmissions to the same or similar hospital or related conditions. So basically on the managed care side and the commercial side, because they don't have access to the Medicare database, they actually are looking where they actually look to see where the patients, if they're coming under the same provider number. We have a lot of hospitals that there may be 4 or 5 different hospitals, but they use the same provider number when they bill. Those are all subject under the commercial and Medicare Advantage plans. And we have started seeing at PayerWatch that some of the payers are starting to identify cases that are in the same health system. So that's very interesting that they have that your health system has a system contract with them that may list all the hospitals in that area. And so because they're now coming all under the same contract, we have started seeing where they've identified some of the readmissions because they're coming under the same health system. Again, go back, make sure you understand what's in the contract and the provider language. If they're going to start talking about people in the same health system, then it ought to be in the contract and not an I got you. Next slide. So let's talk about, I pulled Blue Cross, I pulled United, some of the most common ones. And what I can see as an example is most of them use the exact same criteria for readmission. They don't look at the 6 conditions. They look at all readmissions. Same or closely related, condition or procedure as to the prior discharge, an infection or other complications of care, condition or procedure indicative of a failed surgical procedure, which they try to look for. Do we have decompensation of the coexisting chronic disease, a need that could have reasonably been prevented by the provision of appropriate care consistent with acceptable standards of care, which we see those, and they're always looking for things that they say are premature discharges. One of the interesting things in one of the studies talked about the anything that happens between day 0 and 5 usually concerns them, that they are, I mean, the first week, 0 to 7 days, is premature, and everything over 7 days usually has something else going on with it. But they're very honed in quickly, and we do take, when we look at readmissions and we do an analysis with our group, we do look at the days between when the patient actually come back, as well as looking at the condition. Things that don't count, very interesting, are admissions. They don't count, and I'm seeing this in almost every one of the plans. They don't account for admissions for treatment of cancer, primary psych diseases, transplants, or rehab. Planned readmissions, so they're able to pick up that indicator just like we are. Members transferred from one acute care facility to another, if they're discharged against medical advice, and maternal and neonatal readmissions usually don't count. I looked at United Healthcare. They use the exact same criteria that I saw as Blue Cross. However, they talk about in theirs about the need to combine both of these, both readmissions together. I looked at AmeriHealth earlier, same different. AmeriHealth, this is why we're saying no on the plans, says that the patient is discharged less than 5 days, then you need to combine them both together. And that's, to me, that's good news in a lot of ways. And I would keep this, you, my guys, will keep this in mind. If they are absolutely totally related and they get out of there in, a day or so, you're, in many cases, you're much better off in combining them anyway, because you may be able to invoke your stop loss and receive more money for them. The cases that we've had for some of our hospitals that we write for is that they not only when they come back are their readmissions, many times they're sicker than what they were before. So combining both of them together and submitting that one claim, they tend to fall under stop loss. So you usually get the DRG plus extra money. That's just a little nugget. I think you should also make sure you understand what it is that your plan, what the plan allows, and what the plan tells you of how it's going to pay in that particular instance, because it could be very different. So how do we start this review? Next slide. And I'm sorry, I was just speaking, I was telling about United. Yeah, so United's the same. And here they want you to combine them together, is what I just said. So the criteria are the same as Blue Cross, and I've already shared about the stop loss. Next slide. So how do we start the review? What do we do? What's important when you're looking at readmissions? The key is what's documented or inferred in the medical records. And the starting place that all of the peers start at, and having experience on both sides of the thing, on the peer side and the hospital side, the first place you always start is the discharge summary. Okay, so the questions I'm really looking for is, are the discharge instructions clinically appropriate? Do we have an accurate disposition condition? Is the diagnosis correspond to the workup and any clinical indicators that was identified in the patient? Because when I get ready to write, I'll give you a couple examples. This is going to be very important. Medication, comprehensive and clear, is really important, because a lot of the patients come back and their readmission many times is related to medication. Many of these patients go home, they are still taking the same medications they have at home, plus the ones they got in the hospital. So the question is, how well was the instructions comprehensive about the medication? Was the discharge disposition location reasonable and explained? And do we have appropriate follow-up and time frame? So when I look at the, and I'll bring this up again, you'll hear it again as we go through. I look at the disposition when I say reasonably. Did we try to get the patient skilled? Did we try to get the patient in a place where obviously it was the right disposition? What about our follow-up time frame? If we know that this patient is volatile, are we able to get the patient in to see these primary care doctors within the 5 to 7 days so that they can have a follow-up to make sure everything is going well? Otherwise, they end back up at the hospital. And when we look at these key factors in the record, or when the key factors look at by the payer, the question is, did we have a premature discharge of this patient and all these things? And they're premature if all these things were not discussed. Next slide.
Hey, Reggie,
So,
could
yeah.
I just ask something here, or make a statement? The medication's comprehensive and clear. I think that is so important. And just as an
Yes.
example, my husband was hospitalized several months ago and had some medication changes, additions at discharge, and they were written out as blah, 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 TID, QID. um, I knew what they meant, but the normal non-medical patient isn't going to have any idea what that means. So so be so careful about that. It's so easy. You know, we write that every day of our lives, TID, QID, you know, all the other abbreviations. Be very, very cognizant of that because you can get dinged for that very easily.
Thanks, Carl. It's great. And I have that moving down here below here to have that conversation. Let's talk about the next slide. One of the things that we looked at after we look at the medical record on the next slide, Carla, is we start talking about, is it clinically related? When you read the denial letters, they usually talk about, this patient's readmission is clinically related or close to whatever the language that they use. So the things that we look at is it clinical related? Okay, does this patient have CHF and they're coming back with something that's CHF related? So it's the concurrence or recurrence of for the initial closely related to why they were there before. They were here with CHF, they're back with CHF. We look to see if there's an acute decompensation of chronic problems. So one of the things that they look at that's looked at the claim is they look at everything that was coded. I can see that it said the patient had COPD, okay, and I can see that the patient is a diabetic. They are back now after this admission, and they now have uncontrolled diabetes, and they have COPD exacerbation. To appear, those are clinically related conditions and and are subject to be counted as such when they start deciding whether or not they're going to deny it for readmission. Is there an acute medical complication plausible related to the care from the initial admission? So in other words, they had acute MI. Now they're returning with aneurysm. They're returning with arrhythmias. They have DVTs after they had a hip replacement. I mean, there again, we're going to talk about how to address those, but this is kind of the language that they use when they say, oh well, it's a medical complication, not necessarily, but this is some of the stuff that they go try to use. An unplanned surgery procedure to address a continuation. They're readmitted now. They came in earlier. We're readmitting them now for cholecystectomy. But when they were here last week, they had fever and they had elevated liver enzymes. Or in a couple of cases that we had not too long ago, the patient had a lot of vaginal bleeding. They transfused her, and without setting a time frame, at a later date, she was going to be admitted for hysterectomy. And they said, well, at a later time, we'll give her a hysterectomy. And she comes back 3 weeks later and she's bleeding more than she was before. And at that time, they decided to do the hysterectomy, which probably should have been listed earlier on as going to be a planned readmission for the patient. And then is there a surgical procedure uh, to address complications resulting from the care from initial one, like a fracture dislocation after a hip surgery, a hematoma, or repeat endoscopy intervention after GI bleeding. All those things, they try to look for anything that they can say that was related to the reason why the patient is coming back, because it's clinically related. Although that may be the case, uh, it doesn't negate the fact, depending on the case and the circumstances, that it should not be paid as a readmission, and we're going to talk about those. Uh, Next slide. Uh, it's not because it's not potentially preventable if the documentation supports that we did make an appointment for the patient within the first week. If we did give them the appropriate telephone numbers were given to the patient for calls to the hospital. If an in-home safety assessment was made and there was appropriate follow-up, if we can show that there's written discharge instructions were provided and explained to the patient, and if all the prescriptions that were given, the patient was educated and appropriately, we are able, and we've been very successful at appeals masters, to go back and write some of these. But as I say, it all starts with the medical record. But we can able to find those things to say, even though they're back with this, we've done everything possible to prevent this from occurring. And we have language for that, which I'll share a little bit for that with you going here very shortly. Next slide. The other things that are potentially preventable. Did we have the right diagnosis for the clinical indicators? If risky treatment plans were done, did the consultants document that risk? Did we document the patient had improved sufficiently and was ready for discharge, and all the comorbidities were stable? And if we do a suboptimal disposition, document why. I see that a lot in our charts. I can see where the physician says we wanted to send the patient to skilled. However, the insurance company did not approve it, or the family wanted to take the patient home. That's great. All I just need to hold on to that, because the disposition was not the one that the physician had said. It wasn't the physician. We document a lot when the insurance company, it takes a long time, or when they deny the patient for the care for the post-discharge that the patient says that they had. Did all of the durable medical equipment was arranged? Was it explained to the patient? And that we address any financial and social needs they may have. Next slide. Okay, so now let's talk about formulating the argument. One, again, know the payer's policy. Know which facilities are included, excluded. So, if they're trying to do, like I say, the little game of everybody in the network, that doesn't work, because it's probably not anybody's policy. Which conditions and diagnoses are included? What's the time frame between the admissions and admissions to be considered a readmission? Because we look at that too. If many of them say, after the first 7 days, I mean, this patient, we can actually really show that this patient, they were not prematurely discharged. Make sure you look for any AMIs and transfer. And then obviously, did the payer follow their own policy? Because we will point that out to them many times that they didn't. Next thing in your argument, next slide, would be, is it clinically related? Are the DRGs, the primary diagnosis, different or related? Did the focus of care differ from each admission? And that's really important, and we'll walk through that one. Was the discharge planning complete and appropriate? Was the patient asymptomatic and the comorbidity stable at the time of discharge from the first admission? Next slide. Be exceptionally clear about the events, and we do that. We actually write the roadmap out of them. The patient was discharged in the past 30 days from the inpatient with a diagnosis of this. The discharge was this. There was remitted with this, and we start painting that roadmap. Next slide on the patient. Then we focus on the buck of the pill is dealing exactly why the readmission should be recognized. We do a compilation of everything that happened during the first and the second, and we spell it out. Why is this admission different? What was the diagnosis? What was the focus of care of this one, this admission, when they had the other one? Next one. And then we do potentially preventable considerations. Did the documentation support adequate discharge planning? Follow up with the physicians. We put that all in. I'm gonna share one with you shortly here of us. And as Carla just pointed out, make sure you don't use any abbreviations. The peers will pick that up really quickly to show that the patient the medication was appropriate, that they received, it was adequate, and that they have friendly discharges. And obviously, it's in a lay patient language so that they can understand that they're not medical. Look for next slide. Look for documentation of telehealth, post-discharge phone calls. If your care management is doing follow-up, some hospitals have care managers that actually follow up some very complex patients on discharge to check on them. Any disciplinary team communication of the patient discharge needs, any communication with the community providers, any disease management education. We look for all of those things that we can actually make part of our documentation. Next slide. Did the patient leave against medical advice? Is the patient compliant? So we look for that, and I'm going to share a good case with you in a minute that we're very, very successful in turning over, because physician documentation is really good on the patient, and once you hear some of it, you'll understand where I'm coming from. Is there adequate documentation that the patient caregiver was mentally competent and capable of following instructions? Did we get the financial barriers addressed? Was the non-compliance clearly documented in the record? Next slide. So we also always include the DRG. So here's case number 1. Jane Doe was discharged the past 30 days with a COBT exacerbation. This is her discharge date. This was the DRG that she was discharged with. Next slide. She presented to the emergency room. She's now got chest pain, palpitations, shortness of breath. This is how the EMS found her. We gave her some adenosine, and she had no improvement. She was converted 3 times. She was supported with assisted ventilation, bagging. She's very, very sick. She's now diagnosed with acute hypoxemia, respiratory failure, respiratory acidosis, hypotension, all the things that you see there. This is now her new DRG that she has going on. So we're able to, we go in and say, this is all the things we did first. We know that she was stable. We know that all these things occurred, blah, 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 blah. Yet she's back again. And this is what's going on with her now. In this case, I would also look at how soon she came back. If she came back in 24 hours or 48 hours, if I could, I would try to combine the two, because now that she's on a ventilator and stuff, she's going to use a lot of money, and probably she will end up in a stop loss, and you'll probably get more money than you would just by writing off this one as the second readmission for the patient. So the summary is she's admitted as an inpatient. She's got acute hypoxemic respiratory failure. She's got COPD with exacerbation, chest pain. You can read there. Antibiotics have started. She's an SVT. The SVT was treated during the hospitalization. Her SVT worsened, and obviously the SVT was not part of her prior admission. So there are more things going on here than were before, even though some of the conditions were there. We try to paint the picture of what the difference is in the first and the second admission of why she was admitted. Let's look at case number 2. Case number 2, I have a patient who came in the past 30 days, had inpatient for osteomyelitis with dry gangrene of the left foot, resulting in amputations for fourth toe. He was discharged. He was treated with osteomyelitis. The home health agency reported that he was non-compliant with the treatment. He has a long history of medical non-compliance, poorly controlled diabetes. So I was able to get all that, out of the chart. That was his DRG that he has. Next slide. At the discharge, the home health was set up to assist him with his antibiotics. There was follow-up appointments were set for his visits and infectious. The care team agreed to change his home IV antibiotics from Vanc to daptomycin due to his non-compliance with frequency of home IV dosing. The next slide. On 22, he's readmitted. He has osteomyelitis at the 4th and 5th metatarsal, worsened gangrene, cellulitis, different toes now. He has presented to the hospital for evaluation of progressive swelling of his left foot. He now is requesting a below the knee amputation. We've got a different DRG going on here with this case. Next slide, we go on to say his admission is not preventable. He's got a long history of medical non-compliance that's resulted in his return to the hospital and request for his knee amputation. And really, non-compliance is really equivalent to really AMA in a lot of ways if they're not following up. He had an effective post-discharge plan, and his non-compliance is actually continued of why we had difficulty in trying to save his foot. So the next slide. So the information received from the admission supported 2 separate admissions. This got paid. All discharge planning related to the first was appropriate, completed, and the second inpatient stay was not preventable. And these are considered unrelated and separate admissions, and that's how we got paid. The next slide is how we're now addressing, and many of you see these are frequent flyers, and I have to bring these in. And some of our hospitals, we had some people on frequent flyer. We have people assigned only to write for these individual people their appeals. So we have them kind of divided up. This person, A person, B person, and so anytime they come in, some of these people are frequent flyers. We've been having much success with frequent flyers, which is very interesting. But we also worked with our legal to get some legal language and stuff of how we will put together the appeal of these patients. And then we talk about, please be advised, we followed your policy. The hospital has done everything to control this patient's readmission by providing appropriate care consistent with acceptable standards. And in this case, this patient is due to social determinants of factors. And I think right today, it is right for us to start using those social determinants because that's the hottest thing with Medicare and that people must start considering those. Despite this, your above policy, Ms. Jane's care is consistent with acceptable standards. Our actions to mitigate the readmission and best comply the payer's name with the readmission policy, and we asserted all the actions that we took to mitigate their readmission and emphasized providing appropriate care consistent with acceptable standards. And therefore, based on that, in the interest of fairness toward the insured, we demand that you consider this claim in compliance with your patient. So I was going to read this one to you. You don't have this one, but I'm just going to give you an example of how this may read out for this patient. It said, please be advised in accordance with, and this is a Blue Cross case, Anthem's reimbursement policy. This patient, we did everything within our control about providing appropriate care consistent with acceptable standards. In this case, we named the patients. It is due to or was affected by social determinants of factors outside the hospital's control. This patient is non-compliant. Self-care deficit may have affected her care, including smoking cigarettes, marijuana despite her pulmonary status, and home oxygen use. We got all this from the doctor writing in the record. She has a history of polysubstance abuse. She's admitted to running out of her oxygen at home because her home oxygen concentration was broken, prompting her to have new oxygen orders be placed, and keeping her in-house until nursing could confirm that the O2 was delivered in her house. In addition, she has been referred to skilled and rehab where she's received care. Despite this, the hospitals complied with Anthem's admission policy by providing this patient with appropriate care consistent with accepted standards. Our actions to mitigate the admission and best comply with Anthem's readmission policies include ensuring that she was stable with a return to her baseline O2 requirements prior to discharge, as evidenced by her vital signs and data and provider documentation and discharge summary. Providers offered to engage in palliative care during her severe comorbidities, frequent hospitalizations, and continued failure of self-care at home. She has been counseled on smoking cessation. She's been educated on the need to follow up with her providers. Her nutrition education is provided, specifically outlined ways to comply with low sodium diet. Her heart failure education has been reinforced with medications, blah, 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 blah. And the nursing documentation indicates that the patient verbalizes understanding of these materials and discussions. We were able to pull all that out of the chart. What we've done with the frequent flyer patients is we always put that in. This lady had 5 admissions with in a period of 3 months. Each, as you know, each one stands alone. We put those social determinants in every case that she has opened, and every last one of them got overturned by the payer. Not only they haven't seen the lady now in the last 3 months, so I'm sure the insurance company has gotten a hold of her because they're having to pay for these claims because we've done everything possible to meet her social determinant needs of health, and we're starting to do a lot of that on other cases, and we're starting to see some success, especially when we point out everything that's been done. So next slide is to sum up some of this for you guys. Next slide, Carla. It's all about the documentation. How is the readmission different from the prior? Admitting diagnosis, focus on the care. Potentially preventable. Make sure you document the excellent discharge planning and documentation from the first. Evidence of any patient noncompliance or expected changes in social or financial, and then solid documentation of the patient's resolution of presenting problems and comorbidities at discharge from the first admission. And then I think the next one, Carla, is just the sum up, knowing the payer's readmission policy. Did they follow it? Make sure your narrative tells the story. Be very detailed and concise with your thought process. Again, we talked about medications being clear, making sure the diagnosis responds to the workup. We got a reasonable discharge. If you know that the patient is really bad CHF, 2 weeks out for a doctor's appointment is not going to cut it. We need to get something sooner, that we get them the right follow-up appointments, because a lot of patients are seeing a lot of different specialties. So which one is it they need to see, and they have clear instructions when an emergency condition occurs. So with that, I'm really to open up the floor to see if we can get some feedback or some questions we may be able to answer for you guys, because we seem to be doing, as everybody said, you guys do pretty good with readmissions, but it's because we make sure that we cover the story from start to finish in both of them, and make sure that the work with our clients to make sure that we share with them what we see that's lacking in their readmissions, that they can, and focusing on these social determinants of health.
Reggie, that was awesome. Thank you so much. Tammy, do we have any questions?
Yes, we do. So one question we have is, what are effective CM tools to address the key drivers of readmissions? Our community hospital has many of the socioeconomic issues. Can you provide some direction, tools, resources?
Yes, there is a pamphlet. I don't know if you put that in. It might be on that page. There's a great tool that CMS has published called the Guide for Reducing Disparities in Readmissions. It actually was, it comes out from the CMS Office of Minority Health. It was revised in April of 2024. It identifies all those social determinants of health, and it has recommended strategies and actions. It's called Guide for Reducing Disparities in Readmissions, and you can get it offline off the wide well word from CMS, it's CMS published. Good question.
All right, the next question we have is, what is the best way to appeal if the admissions are the same, but the patient was non-compliant with medications?
Write in those. If you can prove it, you got in the record, make that part of the letter. So we go through the one I just read to you on the patient. All of this stuff about the marijuana use and all this kind of stuff was all, and with medication, it was all in the medical record. We could show that the doctors were like at their wits' end with this patient because they've done everything and they documented everything. So we just highlighted it, lifted it out of the medical record, sent it to the payer. And I suspect that the payer has contacted this patient and told this patient that if they're continue to be non-compliant, they're going to take them off the insurance. We have not seen this patient now in 3 months, and she was coming like every other week.
Okay, so the next question we have is, when the two admissions are related, How do you combine and bill the admissions as one claim? Since it wasn't planned readmission, how do you explain the time gap between the two admissions on the claim appropriately and compliantly?
So that is something that will be taken care of by your billing office. Hopefully, your billing office has a trigger. The places where I worked always had a trigger when because usually it takes 72 hours. Most of them have a claim check for 72 hours for a case to get out the door because of getting the coding done. So if it's in that time frame, they probably have both claims that they can combine together. If it's longer than that, I would say know what the policy is. Like in AmeriHealth says, you have to if it's less than 5 days, you have to do it. Well, the claim's already out the door, so they're going to deny it. When they send it back, then that is something that the billing office would know. They would know once told that they needed to return the money from the first claim, combine both of them together for AmeriHealth, then send it back out the door. So that's something that really, really has to be addressed by your billing department. That's a great question, but they're the ones that are going to have to do that.
The next question we have is, does the payer come back to the hospital related to how the patient was assisted to support any deficits identified per SDOH evaluation?
I've not seen that. However, when we submit our appeals, and I don't, for those of you that are doing and probably do the same, when we do our appeals, we always send a medical record and we highlight the medical record. And in our appeal, wherever we refer them to, like in this one, it's saying all this about the stuff about her usage, all of her social determinants. It lists the page numbers that it can be found on, and we highlight everything in yellow, and we send the record. So the peer doesn't have to come back because they get the record when we send the appeal. The appeal is always attached to the medical record.
Okay.
Great question, though.
The next question we have is, some of the issues we see is related to the computer-based physician documentation. They tend to copy-paste information to their progress notes so that a condition present on day one may not be present on, I guess that would be, it says on discharge, but seems it's based on the documentation that has been pasted. The payer auditor will focus on this even on appeal. Do you have a strategy for appealing with apparent bad documentation?
Yeah, I put some shockers on the system. This is not a, this is a very common issue everywhere um, where there's computer documentation. Our chief medical officer, Dr. Kendall Smith, always talks to the physician advisors about how they need to address that. They really need to address that through their medical staff. And that's the only way you're going to be able to address that. This is not reviewing some of the records. We see the same things where the same things are copied over and over and over again. They're just like cutting and pasting. That really is something that has to be addressed and taken by the medical staff. Great question, though. I don't have a silver bullet for it. I wish I had something that would do some shocking in the system, but we can't do that. But I understand where you're coming from.
So we have another where it says, what about readmissions because the patient family refused the recommendations for DC planning, the first admission, then returned?
Yes, and that we spell that out. If we can get the physician to document that, we put all of that in the letter. Because these are issues for some of the readmissions that bring them back. We should, and that's what we're saying. We did everything right. We should not be held accountable. We tried to send this patient to skill. The patient did not want to go. The family sided with the patient or whatever. The family insisted that the patient be taken home, although the safe discharge that we had selected, that the physician had selected for the patient, was skilled nursing. Or in some cases, we did what we were supposed to do. We tried to go through you, the payer, to get the patient to us what we felt was a physician did a safe discharge place, yet it was denied on your end. And we highlight that in bold because they own that. Belongs to the payer then. or the family. But the only thing you can do is make sure if it's documented in the chart, make it part of your denial letter and highlight it. Great question.
Okay, next question. Regarding frequent flyers, how many admissions can MA plans combine within a 30-day period? If counting the 30 days from the DC date, some payers can combine 3 to 4 admissions at a time.
Yeah, payer specific. It's payer specific if they allow combining. Otherwise, in this case, with Blue Cross, with this patient, it's one at a time. They looked at one at a time. They don't allow for combining, and I don't think the combining does unless it's like 24, 48 hours. I don't remember at Blue Cross. But what we did do is for every last one of those 5 admissions that the patient had, because we had a time frame of when to write them, we made sure that the social determinants and factors was placed in each one of them, and they overturned all 5 of them. Great question.
Okay, next question. What is your percentage of readmission denial reversals?
It depends on the client. I looked at one the other day, one of them, I think it was like 40%, 41 to 42%. Because I do a couple things. We do a couple things. We do the readmission. We determine the time frame between the days. We determine if it's related or non-related. Okay. And then we look at the specifics that are going on. And as you guys know, it's payer specific, but for this one client that we're doing a lot of stuff, it's about 40%. So it's pretty high.
Yeah, I think we're going to have to end this now. We've gone over the 1 hour time frame. Want to thank everybody for attending, and I think there are other questions that have been asked, and we will do our very best to answer them after the webinar is over, and within the next few weeks we'll do our best to get them posted in the ADAM site and right with a copy of the webinar itself. So Reggie, thank you so much. I learned something every time I hear you talk. So, and I'm sure our audience did too. So with that, everybody, I want to thank you again, and I hope you have a good rest of your day, and see you soon. Bye now.
Take care. Thank you.